really great. We have a really great presentation, 3 presentations. And what we thought we'd do is just quickly go through the idea that we started with, this rural roundtable. So go to the next slide. Yeah, we started at HeartCare working with a lot of university-based hospitals, and then over the past 10 years plus, we've focused in on rural healthcare, and we love it. It's really what we want to do. And so we kept talking among ourselves. We said, we should start a forum that we can get everybody together to share ideas, look at questions and problems, and then find some solutions. So that's the idea behind this rural roundtable. But in addition, we want to make sure that we can have all of you get to know each other, through this forum. And if there's a one-on-one way to talk to each other and solve some problems, we'll make that available to you also. So we'll ask you in a follow-up email if you want us to share your emails and phone numbers. Then we'll go ahead and put that list together for everybody to go to. One of the things that our goal is, we do a lot of diagnostic imaging, but we want to make sure that we're looking at other solutions for the rural healthcare marketplace. So we want to be the go-to solution provider, whether there's fiscal reason for it or just the right thing to do. So if you can think of anything that we can help you with in the future, please let us know and we'll jump into it. One of the things that we do when we start any presentation, whether it's internal, with all our employees or external, such as this, is we make sure we go through our core values. And, the first core value that we talk about almost on a daily basis is what we think is the most important one, and that's to do the right thing. And we live by that. And, so when we make sure that you all know that, and it's internal and external. We also want to make sure that we're astonishing, our customers and our patients by taking the best care of them. We feel that our team of employees work as a team to solve problems, and we feel that we work with all of our partner clients as a team also to make sure that we get things done. And we don't think we can be stopped by anything. We're not going to be deterred. So if there's an issue, whether it's finding the right employee or getting the license or getting the accreditation, we won't stop until we get it. And since we do this 24/7, we may as well have some fun too. So we definitely focus on that in our trip. Our first site was in Edenton, North Carolina, which is a small coastal village on the Albemarle Sound 23 plus years ago. And we've expanded into the mid-Atlantic area, down through the south, up into New York, Michigan, and now we're expanding quite a bit out west. This year, we've installed a new system and service up in Powell Valley, Wyoming, where Tommy is right now, and also at Cordell in Oklahoma. And shortly, probably the next 30 to 45 days, we'll be getting started up at Glendive, which is up in eastern Montana. We're seeing a lot of growth for our services. Y'all have been a big part of that as far as, fielding calls from people that are interested, and we thank you for that. We will go anywhere in the continental or even up to Alaska to find a way that we can help people out. So if you could think of somebody we can help, please let us know. One of the happiest days of the year for me is when we find out we did win Best Places to Work. And again, in 2022, we've been awarded Best Places to Work by Modern Healthcare. And what this means is there's a survey that goes out to every single employee in our company, and they ask us, ask them what they're doing well, what we're doing well, what we can improve on. And every year we learn from that, and it makes us better. It allows us to have as little turnover as possible. And as you all know, the big problem in whether it's healthcare or any industry in the US right now is finding people and keeping them. So this is a really good forum to do that. If you haven't looked at it, I suggest you do. They do one sector for hospitals and then another one for suppliers like HeartCare. Even if you do it and just get the information that they send back to you, it really does help us manage the company better. But we're thankful to our employees, and we're thankful to all of you where our employees work, because that's a big part of the reason we've won this award for 6 years in a row. So that's enough from me. Let's get on to the good stuff here and go through the agenda. Our first speaker is going to be talking about hospital and physician alignments. That's Jim Kennedy. Then we're going to have Rochelle talk about their low-dose CT screening program. And then finally, we'll follow up with our infectious disease experts, Dr. Sarpel and Asfour. We're going to talk about their program that they can help rural healthcare providers. So I have some introduction to the field guide. I'm going to go ahead and read these. But Jim Kennedy and I probably don't have to read. I know Jim very well. We've worked together in various hospitals here in Florida. But he's represents hospitals, physicians, multi-specialty clinics, and long-term care providers. He counsels clients on healthcare business transactions, joint ventures, managed care, contracting, risk management, and fraud and abuse prevention. He's a much sought after speaker on the Affordable Care Act, ACOs, clinical integration strategies, and payment reform initiatives. His professional honors include Best Lawyers in America and Chambers USA, and he's a board certified healthcare law by the Florida Bar, which is a distinction earned by less than 1% of all lawyers admitted to practice in the state. He's chair of the healthcare practice at Carlton Fields. And again, I mentioned I've known Jim for quite a few years. One of the finest people I know outside of being an attorney, but as an attorney, he's one of the best attorneys I know. So Jim, I'll turn it over to you.
Okay, great. Thanks, Bob, and thanks everybody. As Bob said, I've been doing this a long time, and today's topic is really, Sam, do you want to move that forward to one more? Yeah, here. One of the things which our hospitals and health systems have struggled with is finding new and innovative alignment strategies with their doctors. So that's one of the things we've been working on a lot in the last few years. And my little presentation this afternoon will go over some of those alignment strategies. Now, the deck that you're looking at today is really much longer, and I've condensed it to just a few key slides. And Bob, feel free, if you haven't, to circulate the slides to your group here. Because I won't cover everything because it's really too long. But what I really wanted to do is look at what are those strategies that hospitals are using to help those physicians who don't want to go into an employment model, but are worried about going it alone. So we're going to go through a couple of those strategies here. Next one, Sam. And one of the things that at least we're seeing in the markets that we're in, so we work really throughout the United States, but this is especially true in our Los Angeles market that we work in our New York City market, and in Florida, that our hospital clients are competing against private equity, venture capitalists, health plans, and large employers for the physician talent that the hospitals need to serve their patients. So it's an unusual situation because most of these non-traditional suitors are not governed by the same rules that we are as hospitals and health institutions. So number one, private equity is not bound by fair market value. So when it comes to trying to buy a practice or employ a physician, they're not subject to those rules that the rest of us are. So it does create challenges for our hospitals, which are difficult to overcome in a very competitive marketplace. Next one, Sam. So here I'm just lay out some common issues and challenges that we see as we represent hospitals. From the physician standpoint, they tend to want to preserve their autonomy. They're looking to stabilize their financial situations. They want to create exit and succession planning within their practices. So if they have senior partners who are getting ready for retirement, how do they backfill? How do they pay out those senior partners? And they tend to want to see increased involvement in the hospital decision-making process. Likewise, from the health system or hospital perspective, it's very important that their physician strategies help capture market share, execute defensive strategy against competitors. We often see that in terms of alignment strategies, and create precedent with individual deals. So what we're seeing is more and more hospitals through these alignment strategies are creating momentum around their physician alignment, so that more and more physicians, when they see the successes that their colleagues are having with the hospital or with the health system, they're lining up and saying, I'm interested in that too. Now go to the next one, Sam. Next one. Okay, so now everyone on this call as an experienced operator knows what's on this slide. But I put them in three buckets: loose integration, moderate integration, full integration. So everyone here, I'm sure, has done recruitment assistance, medical directorships, call coverage, administrative agreements. That's very loose alignment, and it really doesn't accomplish a lot of what we're seeing from the physician enterprise market. Full integration, that's out there, but oftentimes the physicians aren't ready to go to full integration. So I'm going to focus on the moderate integration, service line management, joint ventures, gain sharing, PSAs, MSAs, APAs, because that, to me, what we're seeing around the country is where the alignment is really lining up. And I'm going to try to spend a few minutes, especially on PSAs, because if you're not using a PSA strategy and you're trying to align your physicians with your health hospital, it's really a useful tool, and it can accomplish a lot, and is completely compliant with Stark and kickback. Next one, Sam. So you're probably all familiar with co-management models. But what we're seeing is an evolution in co-management, so that it's just not around, for example, orthopedic implant supplies and having a co-management agreement that allows the hospital to share savings around that. Instead, we're seeing more and more hospitals go to service line co-management, where you really get buy-in from the physicians to help manage the service line. So this is just one example of a cardiac service line that I did not that long ago. And you can see that on the left side, you've got the cardiology physicians as their investors into their part of we'll just call it NUCO. The hospital also is a part, and typically they're 50-50, but there's no legal requirement that you create these as 50-50. And I should add, you can do this contractually. You don't actually have to create a separate legal entity if you don't want to. More often than not, though, we're seeing the physicians want a legal entity. They like the formality of it. They think it better lays out their rights and responsibilities than just doing it by contract. But, so when you look on the left in key attributes, when you see NUCO, don't feel like you have to do it through a NUCO. You can just do it through a contract if you like. But the idea is that whether it's by contract or NUCO, those physicians sit with hospital leadership, whether it's a dyad relationship, a triad relationship, and help the hospital manage the service line. So what we always try to tell our clients or suggest to our clients is, don't give up too much authority in your co-management relationship. Make sure that you preserve to yourself that this co-manager is advisory to the hospital, so that you as a CEO or the CFO or the CMO can always have that final word and say as to how your service line is managed. But we're seeing that the physicians really like this. It gets them much more engaged. They feel like they're really part of the process of governance. They feel like they're really part of the process of running that service line, and it provides a compensation stream to them, which they feel really good about. Next one, Sam. So there's benefits and limitations with all of these, but really, I just would highlight that when you build out a co-management service line, really focus on the efficiency, quality, and costs to align the financial incentives between the physician group or just the physician leader and the hospital. And on the hospital side, realize that from a Stark and a kickback standpoint, sometimes, not all the time, but sometimes their useful life of a co-management agreement around a service line might only be 3 or 4 years. And here I say terms, meaning a term of years, because sometimes you'll see in orthopedic co-management, those can continue on for a decade or more. Next slide, Sam. So gain sharing. Again, so gain sharing is something which has been around for a long time. The Office of the Inspector General, the OIG, recognizes the appropriate use of gain sharing. It satisfies all the IRS regulations if your hospital is tax exempt. And you've got to make sure that your gain sharing arrangement complies with Stark and a kickback, civil monetary penalties, and antitrust. But the real purpose of gain sharing, again, it allows the physicians an opportunity to participate in the downstream revenue on a basis that they have achieved savings for the hospital. So again, it's a tool that allows the physician group to assist the hospital in identifying and achieving cost savings, and a portion of those savings can be shared with the physicians. Again, you've probably all done gain sharing arrangements over the years, but what we're seeing around the country is that there's more and more use of them, and again, in more and more different arenas within the hospital. Next one, Sam. I won't go through this, it's a busy slide, but my suggestion is, because I've seen it happen too many times, in all of my gain sharing deals, I always put a slide like this in to make sure there is a clear understanding by the physicians as to how they're being compensated. So often, if you don't have a really laid out black and white chart as to the funds flow, there's a misunderstanding, and then your alignment strategy blows up. So again, I would just encourage you to always ask, your accountant, your CFO, your lawyer, whoever is helping you with this, put together a slide that shows the calculation and the funds flow, so there's no disagreement about it. Next one, Sam. Oh, we can skip this one. That just compares gain sharing and co-management. So joint ventures. There's a lot of different joint venture opportunities out there between health hospitals and physicians, and they tend to be more on the outpatient, side of the equation. But, over the years, and Bob knows this from our work together, I mean, joint venturing, your imaging facilities, your ASC, your physician practices, your urgent cares, all those things are great opportunities to really partner with your physician entrepreneurs. So for example, we're doing a large urgent care initiative with a health system in the Atlanta area to build out urgent care. And you've got some really, really smart physician leaders who are entrepreneurs who want to partner with the hospital because they see the value of just the brand of the hospital. And you can co-brand these things. The IRS allows for that. But it's just a really useful tool, typically outside the four walls of the hospital. But it's really a useful tool, and we're seeing more and more JVs around the country. Next one. You can skip this one. Employment light, that's what I call the TSA. And I'm watching the time, Bob. The PSA, I think today, in today's world, is the most useful tool out there to align your physicians and with the hospital. Now, because the OIG recognizes PSAs, the IRS recognizes PSAs, HHS does, CMS does, and it allows physicians to leverage, if they can, if the opportunity is there, to leverage, for example, the managed care rates available to the hospital to enhance their own WRVU value in the work they're doing in their offices. I've had, within the last month, a physician leader in urology, in this particular example, say to a hospital governing board, this seems too good to be true, because through the PSA and the MSA and the APA, you can reduce the overall cost that physician group has of their practice, enhance their WRVU rate, sometimes by 30, 40%, and they remain independent. And I mean, I'm telling you, the physicians love it, especially the ones not near retirement. Although we've done some concierge physician practices near retirement because it also provides an exit strategy for the more senior physicians. So when you look at this slide, realize that you don't have to do all three together. So for example, you can do a PSA without an MSA. You can do an APA without an MSA. So you can mix and match these. It really depends on the sophistication of the practice, but why do, oftentimes you use all three? Because each one of these is an income stream to the physician. And then you build an alignment strategy that coincides with these documents so that the physician is much more inclined to bring his or her referrals to your institution than your competitor next door. You've got to meet fair market value, commercial reasonableness, so you'll see that under the APA, but really, so FMV and commercial reasonableness you need on all three of these agreements, and your lawyers would tell you all that. But it's not employment, they're independent, and I can just share with this group, the physicians, when they hear about it, they love it because it accomplishes so much for them. And then you can layer on to this, and I didn't include it in these slides, but you can layer onto this recruitment assistance, you can layer onto it exiting the senior partners if they're ready for retirement. There's so many things you can add on to these. Want to go to the next one, Sam? So this is just an example of a PSA structure. Now I've got to be honest. I mean, can they get a little complicated? Yes, they can, depending on the amount of detail you'll want to put in there. So this is just an example of one that I've done recently. And so, for example, on the left-hand side, does the hospital want to provide IT support? Does the hospital want to do billing? Does the hospital want to do revenue cycle? You don't have to do all those things, any of those things, but you can do them if you want to. And that's, of course, income to the hospital. And likewise, on the right side, there's some things that physician practices, oftentimes they want to maintain themselves. So for example, oftentimes they want to maintain their own benefits package. They want to maintain the right to distribute their income stream without any influence from the health hospital. Next one, Sam. Just this is how the APA works, the asset purchase agreement. Again, you don't have to purchase the assets of the practice. So where you get into the rub here is, are you going to purchase the medical records? More often than not, the physicians resist that. More often than not, the hospital likes to. You don't have to, that's not a legal requirement. But you get more stickiness, I think, between yourself and the practice if you do an APA rather than not doing one. So I do think it's a helpful tool. I think there's one more. Yeah, so just to identify the benefits and limitations, none of these are perfect because if the physician does not want to be employed, there is a reason they don't want to be employed. They want to maintain some degree of independence. And so there are benefits and limitations, as are all to all of these sorts of alignment strategies. Again, this is part of a much broader discussion that we could have one day. But just realize that the PSA, MSA, APA is a really useful tool that the physicians tend to love. And it does bring an alignment stickiness to the relationship between the hospital and the physician practice that doesn't exist without it. So with that, Bob, I will turn it back over to you.
Thanks, Jim. Let's go back one more. So question I have is most of our critical access hospitals or rural facilities, they'll have specialists come in, maybe one day a week or one day every other week from the regional healthcare provider. And what we run into is, they just sometimes just don't show like they want them to. If we have a regional practice, could they do one of these structures at the critical access hospital, like a day or two a week? Could they set one up that way?
Absolutely. That's a really good point. I should have covered it. Yeah, the PSA model can be episodic. It does not have to be full-time. So that's a really, really good point, Bob. So yeah, the short answer is yes, you can do it on that basis.
I think all the administrators on the line would like the word stickiness, because that's what we're trying to do is get these specialists to come to the sites on a regular basis. So I think that might help. Jim has his email address on this, and we'll provide his email address and phone number for those of you that might want to contact him. Are there any other questions that you might have for Jim right now before we move to the next presenter? Okay, great presentation, Jim. I think there's a lot of opportunity from what I can think of the various hospitals we have on the call today. So we'll talk about those.
Okay.
So next up, we're going to talk about CT screening, and we have Rochelle Waddell from Kentucky. She was born and raised in Kentucky, Cary, Kentucky to be exact, and she's worked for Appalachian Regional Healthcare since 1998, which is the same year that HeartCare was formed. She became a registered nurse in 2004. She's had numerous management roles within the ARH system. And the ARH system is a large regional rural healthcare system in Kentucky. And she started the lung cancer screening navigator for ARH in 2019. So she's going to share a presentation with us on her work.
Yes, good afternoon. Thank you very much for having me. As you said, I work for Appalachian Regional Healthcare, and I've been in this role for now 3 years in July. So it's been an exciting 3 years just with our growth and what we have so far accomplished, and we have a lot more to accomplish in lung cancer screening. So just a little bit of house cleaning if you want to go to the next slide. Appalachian Regional Healthcare has been ranked one of the top 10 employers in the state of Kentucky. We have nearly 14 hospitals now. We just added another hospital, which made us 14 back in December. They're spread out through the eastern part of Kentucky, and we have 2 in the state of West Virginia. We also have multi-special physician practices, home health agencies, home medical equipment stores, and retail pharmacies. Next slide. Also, with our ARH mission is to always improve health and promote well-being of all people in the Central Appalachian in partnership with our communities. And our vision will be the premier destination for quality care, a driver advancement and development, and a leader in health, health for communities we serve. Next slide. And you can see our values: trust, innovation, collaboration, compassion, and service. Next slide. Just a little bit about our history for Appalachian Regional Healthcare. In 1956, the UMWA had thousands of coal miners that started the Miners Memorial Hospital. The Systems Hospital were located in a couple of different regions, such as Hazard, Harlan, McDowell, Kentucky, Middlesboro, and even in South Williamson. And we had one in Bakeley, West Virginia, and Wise, Virginia. So in the 1960s, it was announced to close some of those hospitals. And soon after, the Board of National Missions formed a new independent, which was called Appalachian Regional Hospitals. That purchased the Miners Memorial Hospital. The health system changed its name in 1986 to Appalachian Regional Healthcare to more accurately describe its far-ranging services. Next slide. So today with ARH, it's a $2 billion health system operating, like I said, with 14 facilities. We employ approximately 6,000 people with an annual benefit of around $3 million that's generated in our local economies. ARH is the largest provider in care and single largest employer in Southeast Kentucky and the third largest private employer in Southern West Virginia, and is consistently recognized for its medical excellence. Next slide. Now, just a little bit about lung cancer in Kentucky. I know from what I see on the call, there's a lot of different people on the call from a lot of different places. So lung cancer in Kentucky, just some facts. Next slide. Sorry. We are 51 in the nation. We're the last for lung cancer incidents. As you can see there, it's 89.4 out of 100,000 people. And so you can see all of our statistics, but the main one I want to mention is, since I am the lung cancer screening navigator, that is my focus. We are the second in the nation for lung cancer screening at 14.6%. And I think we're behind the state of Michigan, which is number 1. So we still have a lot of work to do and a lot of room for improvement for lung cancer screening. Okay, next slide, please. So this is something I wanted to mention that we're very proud of here in the state of Kentucky, that has a lot of people have been working very diligently and trying to get us up a little bit in lung cancer in Kentucky. So our legislative session with House Bill 219 will be signing into government on Friday, July the 15th, with a bill to develop a state lung cancer screening program and advisory committee that would positively impact everyone's and the overall mission of lowering lung cancer mortality in Kentucky, while amplifying, which is Kentucky Health Collaborative members, and ARH is part of that collaborative, with current lung programs, outreach and treatment, and generate new revenue through increased volumes of lung cancer screening. So we're very excited about that. That is something new that they have been working on for a little bit, and finally have that ready to be adopted with the state of Kentucky. Next slide. So lung cancer screening, low dose lung CT scan. Next slide. Just to make sure everybody is aware, what lung cancer screening is, a process that is used to detect the presence of lung cancer in otherwise healthy people with a high risk of lung cancer using a low dose CT. The goal of the lung screening is to detect lung cancer at a very early stage when it's likely to be cured. And also, I've put smoking cessation on there because everyone that is getting lung cancer screening is a smoker or has been a smoker and should be getting some type of smoking cessation to encourage to quit, to help with our population that is more with lung cancer. Next slide. Most lung cancers are diagnosed at later stages when the cancer is spread to the other organs, so treatment options are less likely to be curative and survival rate is lower. So our ultimate goal in screening is to try to get those that are diagnosed at an earlier stage where it is more likely to be cured, more likely to save the patient. Next slide. So in February of this year, 2011, CMS, Center for Medicaid Services here in Kentucky and across the nation, have had updated their regular criteria for lung cancer screening as to the age that the patient is will meet that criteria. So the age of the patient now has to be 50 to 77, which changed from 55 to 77. So we're capturing those patients that are 5 years younger that have been smoking a 20-pack year history, which changed from a 30-pack year history, that are asymptomatic, that are a current smoker, or that have quit in the last 15 years. So that's a large population here in our state. So we, as I said, we still have a lot of room and a lot of eligible patients to receive those screenings. Okay, next slide. The next slide is just a little bit of a timeline of our lung cancer screening program here for the ARH system. As you can see, it's been ongoing, and we're still ongoing. When I started in 2019, someone else had already started the program. I just picked up where they had left off. And since that time, we have had onboarding of being affiliated with the Kentucky Health Collaborative. We've added a physician champion, which is a primary care physician. We've added a physician champion that is a pulmonary physician. We have developed a lung cancer screening task force that we bring all of those that are represented, whether it be radiology, oncology, pulmonary, cardiothoracic. We have developed that, and we bring those as a group together to get ideas and to get the support that is always needed. We have early liaisons that are engaged in the help with getting that education out to our providers and to our patients. We now offer our low-dose CT screening program, low-dose CT scans in all 14 of our facilities. It says 13, but we now have 14. In October of 2020, we started a nodule review just for our lung cancer screenings, which means that, again, all of those different providers come together, cardiothoracic, oncology, radiology, all of those come together. We take a look at those exams that are in question, which are usually the ones that have suspicious nodules, and we review those, make suggestions for the patient to get better, quicker care, and to make sure that they get exactly what they need in a timely manner. Now, in February of 2021, we started adding additional support staff for this program. Up until February 2021, it was only myself doing the whole program, as many of our facilities in the state of Kentucky struggle with those kinds of resources. Now, come December 2021, we got approval for a lung cancer screening software. It's called Think Health. We are in the process of getting that. As of today, we are about 2 months away from going live, hopefully 2 months away. Maybe I'm just hopeful. And May of 2022, this year, we have started a lung nodule clinic from our lung cancer screening program. It is a service of our pulmonary. We hired a lung nodule clinic navigator for that service. So we are, it's taken a little bit of time, but we are continuing to move on. ARH has taken great interest in lung cancer screening, and thankfully have come on board and provided resources and continue to do so. So it's been a pleasure to work with them and get those resources and get our patients taken care of. Next slide, please. As you can see here, this is a graph of our growth. From 2016, it started November 2016, our lung cancer screening program, doing low-dose lung CT scans with 16 patients. We did 16 patients in 2 months. So 2017, we did 372. Now jump forward to 2021, 1,659 patients were in our screening program for the year of 2021. For the year of 2022, we're already about 500 patients more than what we were this time last year. So we're expecting to reach 2,000. Each year, our growth continues. Our providers are becoming on board. We are doing more education. We're trying to keep the word out to our patients. And so far, I feel like with our government in the state of Kentucky getting on board to try to get us up to speed with lung screening, that our mammogram screenings and our colonoscopy screenings are is only going to be more beneficial. Next slide. So just a little bit about our new service, which is provided in our pulmonary service for lung cancer screening, our lung nodule clinic. Next slide. So our lung nodule clinic is to further improve our patient care. ARH has invested in a lung cancer program that includes radiology management, patient tracking software, and a lung nodule clinic. This program was designed to help diagnose, monitor, and treat patients with lung nodules and other findings that are suspicious for lung cancer. There are 3 broad categories of abnormal radiology studies that may lead to a referral to this clinic. Those include low-dose CT screenings that are with asymptomatic patients, studies that have been performed for evaluation of other symptoms, and incidental findings. Incidental findings is starting to become a focus within our area because we do have a high number of incidental findings just in lung nodules that patients do not follow up on, and then they come back 2 years later and they're already at a stage 4. So we are trying to get those patients seen sooner, and not with the delayed time. Next slide. Just how our lung nodule clinic works. This is a new service, so I've kind of put this in just a little bit more. If lung nodule or other suspicious finding has been detected, the lung nodule clinic navigator will be alerted. The navigator will contact the ordering provider, the patient. The navigator gets those patients scheduled, gets everything that patient needs, gets the patient taken care of before they ever get to that lung nodule clinic to try and decrease that time between diagnosis and treatment. Next slide. So who's involved in our lung nodule clinic? Our lung cancer screening navigator, the lung nodule clinic navigator, our physician champion, pulmonary and cardiothoracic surgery. Next slide. And this is just an example of how I feel that our clinic is coming along and what we've already discovered and the need that we thought that we needed. We've already, in 5 weeks, we already had a total of 44 patients in one of our facilities that we had scheduled follow up and for treatment in our pulmonary service. That just goes to show what is needed in our area as far as getting these patients navigated and just making sure the patient has the correct information and what they may need. Next slide. And this is just my contact information. Please feel free to reach out if anybody else has any questions. I'd be more than happy to answer. And again, I really appreciate y'all having me on and talking about lung cancer screening, and hopefully our next step in the state of Kentucky will start giving us a little bit more of what we can do, and with mammograms and colonoscopies, kind of getting us up to speed with that.
Thanks, Rochelle. Just a comment and a question. We talk about ARH, it's a very large organization, but a lot of the hospitals are small rural hospitals. We work with Morgan in West Liberty, which is a critical access hospital, I believe, and they're implementing this at all of their hospitals. So don't think this is just for the large hospitals. And Rochelle, my question to you is, there are a lot of resources you talked about. If you're a small critical access hospital somewhere that doesn't have a large regional system behind you, do you think this is something that could be implemented at those hospitals?
In a small hospital, I think it still could be implemented. They may not have the resources as much as what a larger hospital will. Kind of like ARH started out small and doing a few hospitals at a time, but I still think, as I said before, with more focus coming on lung cancer screening, more that's going to be available once our government in the state of Kentucky signs this into bill, more money will be available to help those get set up and get going. So in my opinion, I would think that smaller hospitals, everybody's lacking in resources in every department, I feel like. It's just a matter of if you can get people on board to help get those resources started and to get this program started.
I don't want to inundate you with a ton of phone calls or emails, but you're willing to entertain questions after the call, right?
Actually, I'm getting ready to go to another meeting. So if anybody does have any questions, feel free to send me an email. My email is on here. And if anybody has any questions now, I do not mind answering those. But I am getting ready to step out to another meeting.
Okay, so maybe we'll save those questions for email to you later, should anybody have them. Thanks so much. That was impressive numbers. I sat through a presentation up in Gainesville on Monday. I think Florida's like 43. You were 51, but Florida's high incidence of lung cancer here also. So there's a reason CMS is increasing the range of ages and paying for these. So
yes, I agree. And those recommendations that CMS came are not the same as the USPSTF recommendations that came out last year. They actually wanted the age to be 50 to 80, and still CMS went 50 to 77. So, I still feel like that there's a lot more room to improve and maybe some more recommendations with some more data at another time. So it'll be interesting to see what may happen over the next several years.
Thanks so much.
Thank you.
Okay. Well, two really great presentations. I hope everybody's getting a lot of good information from this. Back when the pandemic started, our first core value is do the right thing, and we found another organization that had that same value in praxis, and that's Ramzi and Dost. We started doing these types of webinars for anybody that wanted to join, and what we looked for were physicians that really understood infectious disease, understood as much as we could about COVID at that time. And we did a number of really good presentations, and that's how we got to know Dr. Asfour and Dr. Sarpel. A little bit about them. Dr. Sarpel completed his internal medicine registry and infectious disease fellowship at GW in DC. He completed training in viral hepatology under the mentorship of Dr. Douglas Dietrich, who's a world-known hepatologist. He's also medical director and COO of Katsu Consulting. Dr. Asfour has worked extensively in the treatment and prevention of infectious disease since 2004. He works with long-term care facilities in the field as a consultant. He is the current founder and currently serves as president of Praxis ID. He is an assistant clinical professor of medicine at the University of California, San Francisco, and he has also worked with the World Health Organization. And Praxis ID, who both gentlemen are involved with, their mission is to support rural critical access hospitals and clinics that do not have infectious disease coverage that they require. It's composed of a team of board-certified infectious disease physicians. They provide targeted, timely telehealth patient consultations and critical support of the infectious prevention and antimicrobial stewardship programs. So with that, gentlemen, I'll turn it over to you.
Thanks, everybody. Can you hear me okay?
Yes.
Perfect. Next slide, please. So just a little bit about what we do, and we've been working. Thanks, Bob, for the very nice introduction, by the way, and thanks to our other speakers too for very interesting and insightful. I learned a lot from both presentations. But briefly, we're ID doctors. We do generally what ID doctors do, except we focus on rural health facilities that don't have either enough staff in terms of ID, infectious disease support, or don't have any infectious disease support. And we can go in and we can be involved very deeply in their hospital system, committees, et cetera, or just on an as needed basis. But we offer general infectious disease consultations, but also antimicrobial stewardship, infection control, on-call review of antibiotics. Next slide, please. And we've noticed one of our big initiatives was fluoroquinolone, like Cipro and Levaquin, two antibiotics that are commonly used, are examples of fluoroquinolones. And we had a big project to reduce the use of these antibiotics, which are really overused. There's a lot of FDA warnings against their use and a lot of side effects and including high rates of C. difficile infection, which is a cost and an issue to hospitals. Next slide. So we realized it was a problem. This was the first sort of major project intervention that we did as Praxis, and we were significantly able to reduce the rate of C. diff. You can see on the left, the line represents C. diff, and the bar graphs represent the amount of fluoroquinolone use, or Cipro, and at this hospital anyway, it was Cipro and Levaquin. So this was at a critical access hospital, and we realized a major rate in a major improvement. And actually, for quite a few years, we had 0 C. diff cases at that hospital. We reached out to the outpatient clinics as well. We involved the whole hospital, sort of mini hospital system, and nursing homes around the hospital. We did a big outreach for this project, which was very successful. And I think last year we had 2 C. diff infections, which is also very good. And the year before we had 0. And so we had a bit of a blip last year. Hopefully we'll go back down to 0 again. Next slide. So we looked at emergency department use of fluoroquinolones and realized that more than half of the use was inappropriate. And a lot of the reasons are that somebody might be said to have a penicillin allergy. We've learned a lot about true and sort of potentially not real penicillin allergies, and oftentimes an antibiotic such as the quinolone, like Levaquin, might be used in these cases. So we identified the problem. Next slide. I think we skipped this. Did we skip the slide? This is for the in community acquired pneumonia. The other slide was in urinary tract infections. We actually, even though 60% was so-called appropriate use, we actually strongly advise not using them even for community acquired pneumonia. We developed new protocols and pathways. Next slide. And we were able to significantly reduce the use of both of these antibiotics in a persistent manner. You'll see that more. Next slide. And this is more recent data. This is 2020, 2021. And as you can see, we're still realizing reductions. We've significantly reduced over 2017, and we're still continuing to achieve reductions. 2021 is the gray on the right-hand side. Next slide. We're also targeting costs and cost savings. One of the big things that we can do is really help hospitals reduce unnecessary and expensive antibiotic use. And as you can see, we've had sort of a reduction in overall antibiotic usage 2020 to 2021, and definitely a significant reduction in certain targeted antibiotics. We're trying to use less vancomycin, trying to use less ertapenem, which is very expensive, and daptomycin, which is also very expensive to the hospitals. Next slide. So we've realized cost savings with fluoroquinolone use. Still, this is, instead of doses, this is the sort of total cost. Next slide. And we've reduced costs of some of the broad spectrum antibiotics. The cost got truncated on linezolid. It's relatively inexpensive per patient, but it still can be $100 a day for linezolid. Daptomycin can be $500 to $700 a day, depending on the dose. Very expensive. So we're really able to reduce these. Next slide. This is sort of a cost savings analysis between or spending on fluoroquinolones and spending on all the antibiotics you saw on the previous two slides combined here, more than $50,000. So we were able to save about $25,000 year over year just with antibiotic reduction, but we're not including in this figure cost savings for readmissions, inappropriate care that might have been present had there not been an infectious disease doctor. Next slide. This is Dr. Sarpel. Go ahead.
So what we want to get across is, how do you implement an antibiotic stewardship program, as this is something that Ramzi and I are familiar with and have done. An antibiotic stewardship and infection control program has been recommended for a while now from the Infectious Disease Society of America, or IDSA, as well as CDC. And then CDC actually has recently updated their website, and now they're talking about implementing antibiotic stewardship core elements at small and critical access hospitals. And this is all because of, we're all familiar with CMS. Back in 2019, the current requirements for hospitals to have active and hospital-wide infection prevention and control programs for surveillance, prevention, and control of healthcare-associated and other infections took effect. So most significantly, this rule established new requirements for hospitals and critical access hospitals to have active and facility-wide ASPs to help reduce inappropriate antibiotic use and antimicrobial resistance. So, some of the larger university hospitals have already had this, but then now CMS established this rule that all hospitals, including critical access hospitals, have it. And more recently, skilled nursing facilities are starting to be, well, right now it's state by state. So for instance, for California, skilled nursing facilities or long-term acute care facilities are required to have ASP programs. Other states not yet, but CMS is moving towards that as well. So it's not just the hospital, it's pretty much any healthcare facility. Next slide, please. So how do you implement an antibiotic stewardship program, and where does Praxis ID or your infectious disease physician fit in? So there are two different ways. So one is prospective auditing and feedback, and one is pre-authorization. Most hospitals and most facilities already employ pre-authorization. So that's requiring approval for certain and specifically high cost antibiotics before they're even prescribed. So some examples of these, I believe Dr. Asfour had mentioned, daptomycin, linezolid are more common ones. There are a bunch of antifungal ones. So caspofungin is an antifungal, which can be expensive. And then a lot of the newer antibiotics that have come out over the last 5 years. So ceftolozane, tazobactam is one of 4 or 5 new ones that have come out that are fairly expensive. So the way it works is the pharmacy or PharmD creates this list. Usually there's an infectious disease physician involved. They come up with a list that these antibiotics are very expensive and you're going to need approval from, like I said, either the pharmacy or the infectious disease physician to prescribe them at our facility. So that's the most common method that is employed, and it does produce cost savings. Another method is called prospective auditing and feedback. So this is more of an intervention that usually involves, again, pharmacy or an infectious disease physician in real time engaging the provider after an antibiotic has been prescribed. And this is all because, again, depending on the study you look at or your facility, but at a minimum, at least a quarter of antibiotic courses that are prescribed in hospitals are unjustified. That number actually jumps when you look at long-term care facilities. So both of these methods have been proven to decrease antibiotic costs, decrease the frequency of antibiotic resistance, and decrease C. difficile rates. And there's no negative impact on a patient outcome. And in fact, I believe just last week or very, very recently, a study came out in a journal looking at pre-authorization and prospective auditing in terms of antibiotic stewardship programs and sepsis. I'm sure all of us are aware of sepsis, and they found that it reduced costs, it reduced unnecessary antibiotic use, and it had zero outcome on sepsis protocol outcomes. So like it didn't affect a bad outcome on sepsis. So that just came out. Next slide, please. So this is sort of what pre-authorization and what prospective auditing and feedback entail, the advantages of each, the disadvantages of each. I'm not going to go into detail, but there are strengths and weaknesses for each one. Prospective audit and feedback is typically typically time and labor intensive because someone needs to look through all the antibiotics prescribed and then reach out to the prescriber and have a discussion. Whereas pre-authorization, it's usually built into the EMR, but each one has their advantages and disadvantages. Next slide. Thank you. So this is a real world example. So at a hospital that I worked at, we mainly used pre-authorization. And just before the pandemic started, we added prospective auditing and feedback, and we only focused on 2 antibiotics, ertapenem and Zosyn. So those were 2 of the most prescribed antibiotics at our facility in terms of costs, and they were always on our monthly pharmacy utilization report. Next slide, please. So this is just to give you a sense of what this is from a couple years ago, but what a vial of these antibiotics cost. As you can see, ertapenem was $80 per dose. So you're giving a 7-day course, it's going to cost $570 versus something like ceftriaxone, 7-day course would be $8. So that is why we focused on these 2 antibiotics. Next slide, please. So this is comparing one of the quarters, I think it was quarter 2, so March through May, from 2019 to March to May of 2020, when we implemented the prospective auditing feedback. And again, we were only looking at these 2 antibiotics because they were the most costly antibiotics our hospital was using. So we, by adding prospective audit and feedback to our pre-authorization, we reduced the doses of these antibiotics given, and we had a total cost saving of over $5,000. And again, this is just in a 3-month period when we implemented this, and we were only using, only looking at these 2 antibiotics. Now, what Praxis ID does with critical access hospitals, so this was at a larger hospital, but this was just a good example. But what we do is we typically round every day with pharmacists and the charge nurse. We go over any patient that needs to be seen, and this is all through video. Like they have an iPad, we go through the patients, and then we go see the patient with the iPad using video teleconsulting, and then we give our recommendations for treatment. So that's just the treatment and the consultation piece of this. But what we also do during this time is the pharmacist will tell us pretty much all the new antibiotic prescriptions from the day before, and if it's on a Monday, then it's from the weekend. So it's not just, I mean, it's definitely the high cost antibiotics, but it's any antibiotic that they have a question about. So, and we over time have empowered the pharmacists to be vocal, to talk to providers. We've been doing this for several years now, but and now they know like this antibiotic doesn't make sense. And so during these rounds, they'll tell us, and then in real time, either while we're still on the phone with them or shortly thereafter, Dr. Asfour or myself, we will review that chart, look at the antibiotic, look at culture data, and then get back to the pharmacist and say, yes, this antibiotic is fine, or no, it's not. So that's how we intervened with a lot of the charts that Dr. Asfour showed. Next slide, please. So, we're on call 24/7. We provide ID support for patients, but on top of just patient care, this is how we help the hospital, your critical access hospital, by reducing hospital transfers, reducing readmissions, reducing your HAIs such as C. diff, minimizing the use of high-cost antibiotics, coordinating care, figuring out who's appropriate for oral antibiotics versus IV, so that not everyone gets IV antibiotics. And it has been shown time and time again in multiple studies that early consultation with an ID specialist improves patient outcome, decreases mortality, and lowers costs for the facility while reducing HAI and readmission rates. And as Bob had said earlier in his introduction, we also have a sister company called Capsid Consulting, And that mainly works with long-term care facilities that may or may not be affiliated with your critical access hospital. I think that is the last. Oh yeah, thank you. And then this is just a way to contact us. You can call us, you can go to our website, or you can send an email to Ramzi, and we would be more than happy to talk to you.
And just to mention also, I'm on the board of our local hospital and I'm on the quality committee, which have a meeting tonight, but these infections are extremely, they're bad for patients, to be able to treat them properly, but also, keeping control affects your star rating through CMS. It affects the leapfrog score. So this is something that I think everybody needs to be aware of and have solutions for. So if you're interested, we can make sure you get in contact with Ramzi and Dost.
Oh yeah, definitely. And the leapfrog score, obviously very important, because they look at all this, and patient outcome obviously is the most important thing. So yeah, these catheter associated infections, C. diff, there definitely can be devastating to the patient, can prolong hospital stay. Occasionally, depending, it could decrease the ability for visitors to come. They get gown up and this and that. And so anyway, yeah.
And readmissions and everything else too. So yeah.
Readmissions, yeah.
So 3 great presentations. I think we're kind of almost to the time, but if there's any questions, please let us hear them now. Okay, as is usual on these things, people are pretty shy but we will get everybody's information out so that if there are questions or suggestions, you can start a conversation. I want to thank everybody that participated for the presentations. They were, I'll tell you, blown away. I'm very excited about what we put together here today, and we've taped this. We'll ship it out to everybody also. If you want to go ahead and forward to somebody else, you can do that. But great stuff. So with that,
thank you for having us.
Thank you, everybody.
Thank you.
Thanks, Bob.
Thank you, Jim.